I'm going to talk to you about primary care, and I will try to make it relevant to your context and give you a sense of how you might, and both on behalf of yourself and your clients, interact with the primary care sector to get the best possible service for people with spinal cord injuries. So I will try to increase your awareness of the primary care context in Ontario, situate people with disabilities within that context, particularly people with spinal cord injuries. We will explore barriers to effective primary care for people with spinal cord injuries. And I will tell you a little bit about some of the research that we've done to try to help family doctors do their best for their patients with spinal cord injuries. So I'm going to invite you to begin by thinking about your own experiences in primary care. Try to remember your last visit to your own primary care setting. Remember how long ago it was, what you went there for, whether or not you got what you were looking for, and what the setting looked like and felt like. And then I'm going to invite you to think about your clients, perhaps, or people with spinal cord injuries, and how they might encounter that setting. In other words, your family physician's office, and what barriers they might encounter in trying to receive a good standard of primary care. And that's what we're going to talk a little bit more about. I want to begin with the definition of primary health care because it's a term that has been thrown around a great deal lately, and not everyone means the same thing by it. When I talk about primary care, I mean those services offered at the first point of contact with the healthcare system. The official definition of primary care offered by Health Canada is up there on the screen. Health promotion, illness and injury prevention, diagnosis and treatment. I want to also talk about family physicians, family medicine. Family physicians are a peculiar breed of physicians who are devoted to a long-term relationship with their patients. And as such, they don't like to be called generalists. They don't like to be called generalists. They think of themselves as specialists, but specialists in a lifelong relationship with their patients. Now, many other physicians also have long-standing relationships with their patients, but family physicians sort of pride themselves on the cradle-to-grave kind of relationship with their patients. They're skilled clinicians that work in the community and that are responsible for a defined caseload of patients. And I just want to take a moment to talk about this word patients. I know that people living in the community often don't like to think of themselves as patients, but that's how we're thought of in our primary care settings when we go to our family doctors. We're thought of as being their patients. And while that word may have some negative connotations, it also has the positive connotation that they take responsibility for us and our health at some level. And so I'm going to invite you to hear the good part of that word patient and perhaps not the disempowering, sort of helpless version of that word. Why is it important for us to understand the primary care context and cooperate with primary care? Well, the main reason it's the first place that most people go when something goes wrong. It's their first course of redress or assistance when they encounter a health problem. Family physicians are devoted to the overall health of their patient, and I think that you will find that they are committed to a model of health that is more or less compatible with your own view of your own health. I should just mention, I'm not a family physician, and you've probably realized by now that I am a fan of family physicians and have had the good fortune to work with a number of very committed family physicians. So I just wanted to make that declaration. In most primary care settings, the caseload is typically around 1,500 to 2,000 patients per physician, and that caseload is divided into these three broad categories. In the bottom half is those 72% of people who go to their family doctor with an acute concern, leave with some sort of treatment, and go away on their way to being fully healthy again. That 72% of the caseload consumes about 1/3 of the resources of the practice. Then in the middle, there's another group of about 20, 21, 22% of the practice that have one chronic condition. For the most part, the family physician can look after the needs, or the family physician and a nurse can look after the needs of those patients. And again, they use up about 1/3 of the resources of the practice. Then that tiny triangle on the top is where people with spinal cord injuries are found. People with multiple chronic conditions, multiple needs from the primary care sector, both social and medical needs, and inevitably need the services of more than just medical or professionals, need the services of a multidisciplinary team. So you begin to realize that most family practices won't have more than one or two people with spinal cord injuries in them, if any. And family doctors don't get a lot of experience with people with spinal cord injuries, may have only had one person with a spinal cord injury in their practice in their entire careers. The kinds of issues people with disabilities bring to primary care, some of them are the same as the rest of the population: acute complaints and new health issues, issues that arise normally in the process of aging, and issues of prevention and health promotion. But for people with disability, there are also these other issues, which you all know too well: health issues directly associated with the disability, and complications of the original injury or disability. We've learned a little bit about how people with disabilities use the healthcare system and how that's different from non-disabled people. People with disabilities, according to the National Population Health Survey, make about 3 times as many visits to their family physician as non-disabled people. And this goes across all ages. So they make about 6 visits a year. And if you remember back to the question that I asked you at the beginning when I asked you to imagine your own last visit to primary care, you probably made 1 or 2 visits in the last year. In spite of all that, I'm going to call it excess utilization of health services, people with disabilities also report 3 times as many unmet needs in the healthcare system. Unfortunately, the youngest and oldest and those with the most chronic conditions report the most unmet needs. So those with the greatest needs report the most unmet needs. In talking to people with spinal cord injuries about how they use the healthcare system, we've learned that people evolve complex, intricate maps that guide them through their own personal healthcare system, and rubrics for decision making about what problems to take to whom when. This isn't from our own research, but it intrigued me to learn from another study how people with spinal cord injuries engage with health professionals. In many instances, they tolerate the inadequacies in the provider's knowledge in return for a good relationship. And so they preserve the relationship at the expense of the expertise. In other instances, they become educators of service providers. In other instances, they become managers or coordinators of care. Some people take on the responsibility of doing research on behalf of their family physician or their service providers. Some people substitute institutional care or emergency care for family physician-provided primary care. And other people use specialists for all their health needs, and in fact don't use a primary care physician for the purpose that they're intended. Our own research has showed that people with disabilities encounter barriers at 6 different points when trying to receive service. They have a more difficult time finding a doctor, a more difficult time getting an appointment, getting into the practice, actually gaining access to the practice, using the equipment and facilities within the practice, using the space, using the office space and examining space, and receiving a reasonable standard of care. We've identified 4 types of barriers, and I'm going to talk to you a little bit about each of these types of barriers and how the research that we've done over the last 10 years has helped us to help family physicians overcome these barriers. So we look at physical barriers, attitudinal barriers, expertise-related barriers, and systemic barriers. Looking particularly at overcoming physical barriers, we did an audit, an accessibility audit of 74 practices, family practices in southeastern Ontario, and found that 20 of them were totally inaccessible. The average score was 72%. So I work in an academic environment, and that's kind of what we would consider a low B. So I don't know if you consider that a satisfactory mark. It's probably not what you aim for. Only 15% of family practices that we looked at had an adjustable exam table. And so what most people reported to us was that they examined people with disabilities in their wheelchairs and just sort of tried to poke around and feel what they could feel, or else just took the patient's word for what was wrong. So in your package, you have a checklist that looks like this when you fold it in half. And this was the tool that we used to do this audit. And I've included it in the package so that you can use it. And I invite you to copy it and use it, and to go on the Canadian Disability Policy Alliance website and make more copies and help yourself to it. It is a quick walkthrough, a 5-minute walkthrough of a family practice. You may or may not need to speak to the physicians, but we found in most instances you can speak to an office manager or a receptionist and get the questions answered. So I invite you to avail yourselves of that, both on your own behalf, but also on behalf of your clients. Another project that we did in collaboration with the Canadian Paraplegic Association Ontario was to reach out to the 200 family health teams in Ontario and 25 nurse practitioner-led clinics. These family health teams are kind of a flagship program for this government, and we said, given that you've put so much stock in family health teams, perhaps it would be nice if they were accessible to people with disabilities. And the best thing that you can do is to make at least one examining room accessible. And by that we mean having either a ceiling track lift or an adjustable exam table that allows people with disabilities to be properly examined when they come to their family doctor. So we got approval from the ministry to cost share the cost of this equipment. We sent information out to the 200 family health teams, told them exactly what to put in their budget so that the ministry would approve it. At latest count, we had reached out to 75, and I think 58 had acquired the equipment. So we're due to do another update and check with them just how many of them have gone about getting the equipment. But it was a sort of a tangible outcome that we were very pleased with. We did a survey of family physicians and asked them how their experience with their patients with disabilities was different from their patients that didn't have disabilities. What they told us was that they were less likely to examine their patients with disabilities because of the difficulties of dressing and undressing and communicating about why they had to do what they had to do. And so they just tended not to get examined as diligently. Family physicians also told us that if a person needed that kind of assistance, dressing and undressing, that they required them to bring their own assistant, that they couldn't depend on clinic staff to help them transfer or dress and undress. And so another barrier to access was sort of erected by requiring another person to be involved in the appointment. Physicians told us that they were less attentive to sexual and reproductive issues and less attentive to preventive health care with their patients with disabilities, simply because there were so many things on the list of issues that patients wanted attention to, that those things sort of fell off the bottom of the list, visit after visit after visit. The customer service standard of the Accessibility for Ontarians with Disabilities Act is one way of ensuring equity and an appropriate standard of care for people with disabilities in Ontario. And it's a great tool for advocates for people with disabilities. It says that the disability must be considered when communicating with a customer or a client or a patient, for that matter, with a disability. That service providers have to allow assistive devices, they have to allow service animals, they have to welcome support personnel, they have to let customers know when accessible services are not available, and they have to invite customers to provide feedback. And so we've tried to help family physicians to understand this information, but it's an interesting opportunity for advocacy. Some of you may be familiar with the Healthcare Connect program in Ontario. Healthcare Connect is an arm's-length agency of the ministry designed to help people find family physicians in their own communities. We worked with Healthcare Connect to try to see if people with disabilities had a better or worse record than their non-disabled contemporaries at finding a family physician. It turned out that disabled patients had the same wait time and the same record of being linked with family physicians as their non-disabled counterparts. But the healthcare connectors, which are the staff that act as the liaison between the patient and the family physician, the healthcare connectors indicated that they worked a lot harder for their patients with disabilities to achieve that link. That some physicians' offices simply were not willing to take patients with disabilities. Of course, they couldn't do that explicitly because it's a human rights violation, but there were physicians' offices that simply said they couldn't do it. And so the Healthcare Connect staff were very, very committed to their patients with greater needs. And if you have a client who's looking for a family physician, I commend the Healthcare Connect program to you, and particularly the Healthcare Connectors, as they're called, the workers who help to liaise patients with family physicians. In the course of another study, we did a survey of the knowledge of family physicians about spinal cord injury, and the average score was 2.9 out of 5, and that's an average score out of the number of questions, which is, again, kind of a low B, at the high end of poor. What family physicians felt least capable of dealing with, or least prepared to deal with, was when to refer and to whom, social and community supports that were available, issues of access and human rights, medications covered by the provincial formulary, current literature on spinal cord injury, long-term effects of spinal cord injury, and treatments for common spinal cord injury issues. So I suggest that we can't ask family physicians to know every single last thing about every condition that they treat. Most of them, as I mentioned before, will only have 1 or 2 patients with spinal cord injuries, and so they seek resources that can help them to understand the complexity of the patients that they deal with. And in many instances, I suggest that you may be in a position to be those resources. And it's been my experience that family physicians have welcomed that input and basically are looking for anything that can help them to do a better job for their patients. We did a chart audit in, again, 74 physicians' offices, family physicians' offices in southeastern Ontario, and compared guideline compliance on 5 conditions between disabled patients and non-disabled patients. And we found that guideline compliance was better the more time physicians had to devote to their patients. And so salary practices, it turned out, were the ones that were able to offer the longest appointments and the most flexibility in terms of how and when they saw patients. So practices like community health centers. and they performed better in terms of guideline compliance on these 4 conditions: urinary tract infection care, preventive health care, hypertension, and diabetes. They were no different on skin care, so it seems like skin care is equally well dealt with regardless of the type of practice. The take-home message that I offer to you from this one is to encourage your patients to ask for more time. Most family practices have longer appointments available, but you have to ask for them. And patients with disabilities certainly are the ones who need those longer appointments, so you may have the opportunity to encourage them to ask for those appointments. We did a scoping review on the literature that is out there in the primary care literature, helping family physicians to understand spinal cord injury and some of the care guidelines and issues faced by their patients with spinal cord injury. And that article is coming out in the Canadian Family Physician Journal this fall, so watch for it. It's been a long time in press, and we'll be very glad to see it out there. So you may wish to direct family physicians to it when it comes out. The last thing that I want to draw your attention to is a program called Actionable Nuggets. And this was a research project that we undertook to get information into the faces of family physicians about spinal cord injury. And one of the things we realized from our long experience of dealing with family physicians is that it has to be quick, it has to be to the point, it has to be attractive and attention-getting, and it has to tell them what to do. Not send them off to read something, not send them off to consult a website, but say, just do this. We've done the homework, we're convinced, just do it. So we designed this series of postcards, and I'll put them up here for you to see. That's just a photograph of the front and back of the cards. The whole package looks like this, and there's 20 cards, and they cover 20 of the most pressing issues that family physicians encounter with people with spinal cord injuries. They arrived 1 a week for 20 weeks at the offices of about 60 family physicians in Ontario, Newfoundland, and Australia that were our pilot sample. And if nothing else, they raised the awareness of family physicians about spinal cord injury. Family physicians loved them. They said things like, I love that I can read them standing up. I love that they tell me exactly what to do. I love that they don't make me, go away and read some great long thing. And I love that they're evidence-based and that they summarize a whole bunch of studies, not just one study. So we are currently working with the Canadian Medical Association to get these nuggets, actionable nuggets, out to the 50,000 primary care physicians in Canada. And we think they'll start to be delivered in January of 2013. Again, something to watch for and to encourage your family physicians to watch for. As you probably have heard, the National Health Accord is being reviewed, and through the Canadian Disability Policy Alliance, we took the opportunity to draw the attention of the Health Accord, or the Senate Committee reviewing the Health Accord, to the issues of people with disabilities in primary care, and asked them to include a recommendation that in their accountability framework, the issues of people with disabilities in primary care be particularly targeted and ensured. And that recommendation has been adopted by the Senate committee. So it has been a good experience for us in terms of understanding the opportunity for advocacy, and I encourage you to also, if you have an opportunity like that, to take it up. The Built Environment Standard of AODA will soon be in force, and it will be a great opportunity for advocacy. Why is primary care so important to people with disabilities? They've been described as having a thinner margin of health, which I think is a very interesting and evocative way to describe the potential multiplying effect of health conditions layered over top of a spinal cord injury. People with disabilities have fewer opportunities for health maintenance and health protection. An earlier onset of chronic diseases. Disabilities typically cause a prolonged course of illness or ill health, and there are greater functional consequences of illness for people with disabilities. So I thank you for this opportunity to share our research and invite you to welcome opportunities to work with family physicians to do what they wish to do, which is to provide their best possible care to their patients with spinal cord injuries. Thank you.